Hi again, Yamam. Are you online?
Hello, yes.
Okay, fine. So I will start to introduce you again. We are very proud to receive you in our webinars. This is second time.
Thank you very much.
Second time. You are very welcome.
Thank you.
I will speak in French and in English if you don't mind. Donc, tout d'abord, je vous souhaite la bienvenue, Dr Mouradi. Je souhaite à chacun de ceux qui sont en train de suivre ce webinaire la bienvenue et une excellente journée ou soirée. Dr Yamam Mouradi nous avait déjà gratifié l'année passée avec une présentation qui était relative à ce qu'on appelle Neurological Visual Rehabilitation in Pediatrics and Adults. C'est la réhabilitation visuelle neurologique en pédiatrie et chez les adultes. Donc, on avait une belle présentation. Ça s'est déroulé le 27 mai 2021. Et aujourd'hui, presque un an après, nous allons avoir le plaisir de la recevoir dans cette nouvelle présentation, une sorte de présentation assez générale sur la réhabilitation visuelle neurologique, notamment dans les cas de concussion ou dans les cas de traumatisme crânien, etc. Donc, Dr Mouradi est de nationalité syrienne. Elle est installée aux États-Unis depuis quelques années. Donc, là, c'est une belle image de Damas, de Dimashq. Donc, c'est juste pour un petit peu la mettre dans le bain. Là aussi, c'est une belle perspective. On a aussi, Dr Mouradi est une personne qui est ancrée dans des racines, puisque elle a un de ses grands-parents, c'était carrément presque, comme on dit, c'était un saint, quelqu'un de très cultivé dans le sens religieux du terme. So I have introduced Dr. Mouradi. Now I will try to give a brief description of what she has been doing since she arrived to the States. She has actually done a degree on philosophy. After that, she went to the Ketchum University in Southern California, College of Optometry, where she has done her OD optometry degree. She's a member of the American Optometric Association and the California Optometric Association. She is also certified in CRT, which is a kind of orthokeratology techniques. She has been awarded several awards. One of them is the John R. Griffin Award on vision therapy. Also on Special Olympics and Lions Club Case of Excellence. She has also had a certificate of recognition for community service. She's very involved in community service and social involvement in the community around where she is living now, and also for some reasons around some other places which has a link with her history. Her special interests include neuro-optometric vision therapy, acquired brain injury rehabilitation, sports vision enhancement, and special needs exams. When not working, is involved in several services, and she is also directing site and sketch grassroots Southern California Optometric and Humanitarian Relief Project. She is a co-founder of this organization. Donc, j'ai présenté là, par la suite, vous pouvez le retrouver cette présentation dans la rubrique fichier. Elle est jeune, mais elle a vraiment contribué dans pas mal de choses. Et puis, la neuro-optométrie, ça nous intéresse tous. En pratique optométrique, parfois nous la faisons sans nous en rendre compte quand on s'occupe un petit peu des problèmes reliés, des problèmes qui sont reliés un petit peu à l'amblyopie, aux autres aspects liés à la malvoyance. Elle a aussi rédigé un certain nombre d'articles dans Optometry Times et dans d'autres revues. Elle nous a mis au fait aussi, elle nous a honoré en nous mettant dans son site comme étant le projet que nous avons initié l'année passée et cette fois-ci aussi au niveau du cours qu'elle va présenter. Donc, si vous voulez par la suite, vous pouvez avoir le link Neuro-Vision Rehabilitation Organization, qui est une organisation pour la NORA, qui est une organisation qui permet un petit peu qui est très reconnue aux États-Unis. Elle a même été reconnue par Clinton, au temps de Clinton, quand il était président. Il a honoré les membres de cette organisation qui joue un rôle important dans la prise en charge de tout ce qui est déficit visuel post-traumatique ou déficit visuel de naissance liés à des problèmes corticaux. Donc là, c'est quelques définitions de la neuro-optométrie pour les gens qui veulent s'intéresser. Donc, on peut citer des choses que nous pratiquons: évaluation complète de la fonction sensorielle motrice, du champ visuel, l'accommodation de la fonction chromotrice, évaluation du traitement visuel, examen de santé oculaire, tests spéciaux tels que les services d'électrodiagnostic, les options de thérapie, coordination des soins avec d'autres professionnels de la santé et spécialistes de la réadaptation tels que les écothérapeutes, etc. Donc, là, c'est quelques mots pour Nora. Sur Nora, donc, pour les gens qui seront intéressés de pouvoir, si vous voulez, avoir le lien et puis essayer de se renseigner ou de s'informer aussi pour devenir membre de cette organisation, il y a plein de possibilités pour évoluer dans ce domaine. Alors, le président Bill Clinton a personnellement approuvé le travail de Nora en 1993, comme je l'avais dit tout à l'heure. Et là, donc, ce sont des informations. Donc, bienvenue et merci encore une fois, Dr. Yamam Mouradi. We welcome you again and we thank you a lot, Dr. Yamam Mouradi. You have the screen.
My pleasure. Thank you. Thank you for this wonderful introduction and your research, in being very comprehensive in the introduction. I appreciate it. I'm very excited to do a second lecture, and hopefully this is one of a series of lectures that we may be doing for FCO this year. And so we are going to be talking about neurological visual rehab. It's a general introduction to it, what it is, who are good candidates for it, just to give you an overall recap from the last time, as well as delve into the details of the evaluation process and the therapy itself. So if I can share my screen, and we can start the presentation.
Okay, we got it. That's good.
Okay, perfect. And so my email is in this first slide. If anybody has any questions after the webinar, feel free to email me at any time. If you have any cases that you, as I talk about the different symptoms, if some of your patients jump at you, with the similar symptoms, feel free to, if you want to ask about any cases, you can email me as well. Okay, so overall, we're going to discuss the visual efficiency issues that's under the umbrella of neurological visual rehabilitation, the role of vision in acquired and traumatic brain injury, ABI or TBI. We will go over the etiology and pathophysiology overview of ABI and TBI, and the most common visual symptoms in traumatic brain injury. And then under pediatrics specifically, we will also be talking about cases with ADD, ADHD, autism, and case samples with these two diagnoses, and how vision is sometimes overlooked, and everything is kind of put under an umbrella of the diagnosis of ADD or autism, where we can actually, there are ways with optometry and ophthalmology that we can help relieve some of the symptoms and some of the behavior. If not all of it, sometimes it's pseudo ADD and it's just a vision issue. And then we will end with a visual efficiency evaluation and the visual information processing evaluation, what it entails, what are the subcategories in it. So if you would like to repeat something like this to your patients as needed, and then we will open it up for Q&A. Feel free to stop me at any time if you have any questions or if you want to discuss a certain case that sounds familiar from what I'm talking about. I definitely don't want to be talking at you. It's more of an interactive lecture. So the first part is neurological visual rehabilitation. So this is known as vision therapy. It is an individualized treatment program prescribed to alleviate conditions like amblyopia, strabismus, accommodative paresis, eye focusing issues, convergence and divergence insufficiency or excess, motor coordination, visual information processing deficiencies, which is linked with motor coordination, and other learning-related visual issues like problems reading, problems with comprehension in school for kids, for example. This benefits both pediatrics, adults, and geriatric populations, as well as special populations such as autistic patients. And so, as we know, the brain is very plastic. So you can always reteach it and rehabilitate it at any time. There's not a clear cutoff where after it used to be in books before where up to maybe 11 or 12 years of age, they say, vision therapy is done. But we also do it with traumatic brain injury, with stroke, motorcycle accidents for adults. So that plasticity really allows us to continue to rehabilitate all kinds of patients. So we'll start with visual efficiency, which is really the mainstream portion of vision therapy. We will talk about the symptom etiology and then 3 of the most common diagnoses in visual efficiency evaluation. So convergence insufficiency, accommodative paresis, and saccadic dysfunction. So the first one here, we're going to talk about it's an ocular misalignment and other neurological visual deficits results in asthenopia or visually induced trigeminal dysphoria. And so, this includes, asthenopia includes headaches, eye strain, dry eye sensation, neck and shoulder pain, anything that really has to do with the head and neck. Usually, we want to start with a primary care exam where we get the patient in their best corrected vision, whether it's lenses and prisms or just, bifocals, lens decentration. So all of this will have to be first. And then from there, if the symptoms are still occurring, then we go to active therapy. And so we want to basically overstimulate the trigeminal nerve in order to alleviate this asthenopia and trigeminal dysphoria via active therapy. So with convergence insufficiency, it is basically the eyes are crossing, but they are not crossing enough. They're not adequately crossing at a specific distance for wherever the visual demand is for reading. And so this interferes with the person's ability to see, to learn, to read, to do anything close, any close work without experiencing symptoms. Common symptoms, one of the main symptoms that I see is blurred or double vision with convergence insufficiency. Also frontal headaches because the eyes are working so hard to cross that person is working a lot harder than everyone else to achieve the same results. And so with time, the visual system fatigues easier and stamina is decreased. And so we get headaches. Difficulty reading, difficulty concentrating, sleepiness when reading, because again, the visual system tires out very quickly. So the whole body fatigues. So a child who sees one of those 2 blur or double vision can actually pass a vision screening at, for example, in schools, when we do vision screenings, they can still say, I see this letter is an A or a B, but that doesn't mean that they're not having issues. And so a lot of those screenings overlook some of the visual efficiency issues. Double vision can also look in different ways. It could be vertical, horizontal, or a combination of the 2. And so that's CI, convergence insufficiency. The next kind of main diagnosis under visual efficiency is accommodative paresis. And so accommodation is our ability to keep things in focus for a sustained amount of time without tiring out, losing stamina, getting things to become blurry. And so it is a sensory motor anomaly of the visual system. It has nothing to do with the glasses. They could be best corrected and still see intermittent blur. Because it is an eye-brain relay center. So it's different than correcting myopia, hyperopia, astigmatism. There are two different subcategories in this main diagnosis: accommodative insufficiency and accommodative infacility. Accommodative insufficiency is the inability to sustain focus and clarity when looking at near objects. So for a sustained amount of time of reading or near work, things become intermittently blurry. Sometimes when they go blurry, they don't go back, and the person has to just take a break and not read for a while until it comes back. Accommodative infacility, a little bit different. This one has to do with the neuroplasticity when shifting focus between distances. For example, copying from the board, we have to clear things up close, and then we have to switch to clear things far away. And the rapid switching, if there isn't that neuroplasticity stamina available, will cause issues of blur. And so, as you know, our pupils are like camera lenses. If we're looking like a macro shot close, we have the pupil has to constrict, then it has to relax to look far away. And if there is a disrupt in the neuroplasticity, then it won't be as efficient in making those rapid switches. Some common symptoms, intermittent blur is one of the main, the biggest one. Frontal or temporal headaches with near tasks. And again, it's because we're overworking the visual system that doesn't already have the tools of this neuroplasticity. So it tires out. Ocular discomfort, a pulling sensation from around the eyes, the temporal side. Ocular or systemic fatigue, diplopia, motion sickness, and loss of concentration during a task. This loss of concentration has, of course, there are multiple diagnoses that could lead to a person's loss of concentration. But when things aren't clear and you feel tired and there's a lot of effort when you're looking at something, then you're not going to be able to continue looking at it. And so loss of concentration is one of the main things on that symptom checklist. Blur can be debilitating. It's not just a little blurry. It could sometimes be referred to by patients as double vision, because as you see here, the blur is so much that it's smearing the letters that they look double, even though they might, when you do their cover test check, they might not have any exotropia or large exphoria. It could just be accommodation. And then the third one is saccadic dysfunction. So this is an eye movement disorder caused by deficiencies in ocular fixation, pursuits, or saccades. And so saccades are very small eye movements we make when we switch from word to word or letter to letter. We use both central and peripheral vision in order to make these saccades. And so we're looking at one word centrally, we're anchoring ourselves into the next word peripherally. And ideally, we want to do one smooth transition between the first and second target. And so with saccadic dysfunction, there could be undershoots or overshoots, where the eyes make an involuntary stop halfway through before the target, or overshoot the target and come back. And as you can imagine, if this is happening for every single word we're looking at, reading is going to suffer, comprehension of what we just read is going to suffer, and you're basically, it's like you're overworking, and so fatigue will occur more rapidly. So common symptoms: slow reading, because again, we're making way more too many eye movements than we need. Loss of place when reading. So one of the main things I ask, especially for school-aged patients, is do you use your finger or marker when you read? And otherwise you're skipping lines or rereading the same lines. And because of this, there is decreased comprehension, because the patient is relying heavily on the mechanics of reading, that by the end of the paragraph, they don't really know the content of what they just read, just that they got through it. Frontal headaches, chronic headaches, ocular discomfort and fatigue with near tasks, And then poor sport performance, because if they have gross saccadic dysfunction, not just fine-tuned ones, then they would be having issues with tracking an object, so a ball, batting, maybe looking and seeing where everything is, trying to react quickly enough in a field or court. And so lack of coordination, also visual motor dysfunction plays a big role into this. Slower reaction time for a visual stimulus. And then going back to the classroom, difficulty with math, with number alignment, or the comprehension of word problem, which just becomes reading again. All right, so before I go on, is there any questions? Okay. So neurological link to vision. And so now we're going to move on to more of the traumatic brain injury and acquired brain injury diagnosis. Under traumatic brain injury, there is closed head injury and concussion. Under acquired brain injury, one of the most prominent that one is stroke. And then we'll go on afterwards to pediatrics. So types of acquired brain injury, we have in acquired brain injury, there is external with TBI. So this is where something is happening outside to the brain, like an accident, for example. And under that, there is open and closed TBI. And then there is internal, so a cerebral vascular accident, AVM, surgery complications. So these are things that are happening internal to the brain that will create ABI. So the etiology here for closed head injury and concussion, if you look at the pie chart for the major causes of traumatic brain injury, one of the biggest cause is falls. And so fall with a trauma to the head. And that happens a lot with our geriatric population. And the second right under that is the motorcycle vehicle accidents. So it's usually car accidents would do it, but motorcycle accidents are a lot more traumatic on the brain. And so that is usually where we see a lot of the survivors having TBI. It is a silent epidemic. And so this is a survey that was taken between 2002 and 2006 about just kind of comparing things like HIV, breast cancer, MS to traumatic brain injury. So we hear a lot about some of these other, devastating issues, of course, but looking at the numbers, traumatic brain injury far exceeds it, but it's not really discussed as often. It's often overlooked. And this is a comparison by age. And so in 2014, the CDC estimated that, the older the patient gets, the more likely he or she is to experiencing traumatic brain injury, mostly like we saw because of a fall or lack of balance that creates this fall, also strokes. And so 75 plus, you see a surge in traumatic brain injury. All right, and then this one right here is we're looking at worldwide TBI burden. This was in 2018. So the number of cases are in millions that you see at the bottom here. And so the Southeast Asian region is the most here. And you can take a look at all the different, by continent where TBI is seen. So it's a problem worldwide. This is not specific to any gender or race. It's just an issue. So with traumatic brain injury, the pathophysiology, there is for any traumatic brain injury, whether it's a fall or a motorcycle accident, there is a coup and a counter coup. And so the object that the brain or the head hits makes the brain shake one way, and then the counter coup is when it goes back. And so that portion is what we are interested in vision because of the visual cortex being in the back of the head. And so depending on where that damage is exactly is, really depends on what the diagnosis is more specifically, where it comes to visual information processing. And so no patient is the same as the other. Even if they have similar symptoms, their reaction and how they take to the therapy is different. And the severity, depends on that body's strength to begin with, where it was hit, a lot of, emotional and psychological stability for that patient, and realistic expectations before we can start vision therapy. That all comes into play. So here the etiology of TBI we touched on a little bit earlier. So high contact sports like American football, boxing, falling, or any injury that shakes the brain. Most common ocular symptoms are accommodative dysfunction, convergence insufficiency, saccadic dysfunction, and concentration difficulties with near work, and photophobia. We usually don't treat photophobia with vision therapy, but you will always see that in those patients. So with a closed head injury here, the most common ocular symptoms, visual efficiency dysfunction is 90% of patients, feeling overwhelmed in a busy setting, 82% of patients. So this is whether they're just entering a store that has, filled shelves with a lot of different colors, or being stuck in traffic and just feeling overwhelmed with everything that's going on around them. 55% of patients experience double vision and eye strain, and 33% experience headaches with near work, so frontal or temporal headaches. So more specifically here with concussion, high contact sports and falling could cause concussion. And the most common symptoms here are very similar: accommodative dysfunction, convergence insufficiency, saccadic dysfunction, light sensitivity, concentration difficulty. So TBI and neurological visual rehab. Basically, what we are trying to do here is to treat their asthenopia and ocular trigeminal dysphoria symptoms. We will start with getting their full correction, using prisms as necessary to neutralize any strabismus or any issues that they may have if they react well to prism. And then from then on, we would be treating, this is the active treatment part, for any underlying eye teaming and visual information processing issues. And so we want to actively rewire the brain to correct the process of visual stimulus lost to brain injury. And so this is by practice. It's a process that takes a while. It's repeatable because you have to repeat it to teach the brain these pretty much now they're new skills for this brain after traumatic brain injury. And so one of the most useful tools I have found to, one, flag these patients, and two, understand more about their specific situation is an acquired brain injury visual system checklist. And so this is a checklist that is by frequency. So it is subjective to that patient, and you have to take their ocular history into account, and what their correction is, if they've had any other previous trauma, any medications that may interfere with blur or double vision, and then the symptom frequency. And so those two put together really gives you an accurate prediction as to the candidacy of this patient. So the acquired brain injury visual system checklist is highly accurate in predicting the presence of a visual dysfunction. Usually when we are looking at this, it goes from never to sometime to always, and everything in between in frequency. And so if they circle at least 3 of these symptoms with sometimes or more frequent, then it gives you a good idea that they will be benefiting from vision therapy. So moving on to internal ABI and the stroke pathophysiology, there are 2 different kinds. There's a hemorrhagic and an ischemic stroke. Hemorrhagic, the blood is leaking into the brain tissue and into the visual cortex. And so that's the portion that we are interested in as an eye professional. And then ischemic, where a clot stops the blood supply to an area of the brain. And if that area happens to be the visual cortex, then there would be our issue. In internal ABI, or specifically in stroke, the most common ocular symptoms post-stroke are visual efficiency dysfunction. 87% of stroke patients have visual efficiency dysfunction of some sort. Visual field loss in 67%. So part of that is visual neglect and clumsiness. And then 57% have ocular motor dysfunction. So reading difficulty, feeling overwhelmed in busy settings, and then 13% have accommodative dysfunction. Stroke patient recovery. So there are multiple residual deficits after a stroke, not just visual, but all around. It usually takes up to 2 years post-injury to reach stability. However, each patient is different. And so we have to take it case by case. The neuroplasticity continues over the patient's lifetime, like we talked about earlier. And so it's never too late to recover at least some of the visual information processing or efficiency skills. I have seen patients that were 9 years after a stroke, and they were still benefiting from vision therapy once they started 9 years later. And so, it was well beyond the stability portion. But ideally, you want to start right when the patient is stable, emotionally, physically, medically. And so, but that's just to say that it's never too late. We can always go back and try to fix, even if it's just the portions of activities of daily living, that's going to make a difference in the quality of that person's life. So now, we're done with the traumatic brain injury and ABI, TBI, and mostly in adults. And we're going to move to attention deficit disorder, which is usually detected earlier in pediatrics. Are there any questions up to this point about the adult and pediatric portion? Okay. So with ADD, many children with visual and learning processing deficits.
Yamam,
yes.
Just ask you a question about with which kind of means are you diagnosing CVI at the level of your practice? What do you use as a? Is it just the checklist and trying to get the history of the case, or do you do other tests?
Yes, and so that is the entry point for the patient, just so I have enough history and symptoms on a subjective portion. But then afterwards, depending on these symptoms, we would do either a visual efficiency evaluation, a visual information processing evaluation, or both. And so at that point, I have the clinical data in order to diagnose and see if they're a good candidate for vision therapy. But that is just to know that they are in fact also symptomatic. And so right after the pediatric portion, I will go over the exam itself, both visual efficiency and information processing.
Okay, thank you.
Mm-hmm. So with ADD, many children with the visual learning and processing deficits are diagnosed with ADD, and it kind of becomes an umbrella diagnosis that includes any behavior, any problems learning, where sometimes it could just be a visual issue. So with true ADD and ADHD patients, they frequently have accompanying visual information processing deficits that lead to a notable symptoms in their behavior, their academic and sport performance. So that's not to say that they don't have ADD, ADHD, but these symptoms, when they're reduced, the behavior significantly improves. So both visual information processing and visual efficiency evaluations are necessary to get a comprehensive idea of what are all the deficits, to pinpoint all the diagnoses for these patients before moving on to therapy. So here's a case example. A patient was a 7-year-old male, no significant developmental history. He passed the school screenings. He was 20/20 in each eye, unaided, didn't need glasses, distance and near was clear. But the chief complaint was that he was a slow reader. He was disruptive in class. And teachers said he was lazy and didn't want to do his work, always looked out the window, didn't want to read. So both his mother and teacher were frustrated and concerned that he will be held back a year because of this. He was diagnosed with ADHD, and he was, when I saw him, he was on meds for 6 months already. And so these meds just calmed him down, and he was just now not disruptive in class, but he was still having all the issues with his academics and problems reading and not liking school, not wanting to do the work. And so after doing the binocular visual evaluation, he was a good candidate for vision therapy. He needed 30 sessions of it. Usually these are weekly sessions. And so once these sessions were done, he graduated both in office and at home vision therapy, both programs. It actually showed that he did not have ADHD after all. It was just an underlying visual condition that when solved, he now all of a sudden likes school because he can read. It's not difficult. And, with kids or anybody with untreated visual issues, they don't have anything to compare, to. So when they see things are blurry, they just think, oh, this is how everybody sees, or double. And so they can't really say, I have a vision issue. They just say, well, I don't like what I'm doing because it's too hard. And so this patient no longer needs meds. So at 7 years old, he was for 6 months taking medication with side effects, of course, because all medications have side effects. He no longer needed it. And so, this is one of the cases where it wasn't true ADD, but a lot of patients really slipped through the crack because of this, just the lack of knowledge about visual issues. And the second main special pop diagnosis is autism, another big umbrella. The most common signs with autistic patients the visual signs are accommodative paresis, convergence insufficiency, and visual information processing issues, such as visual motor, visual memory, visual closure, figure ground, poor eye contact as well. These symptoms are eliminated with neurological visual rehab. It's, autism, as you know, has a wide spectrum. There's a lot of variance in patients all under the same diagnosis, and all of them would benefit from vision therapy to some degree. Just the poor eye contact itself is one of the main behavioral symptoms, that all autistic patients share. This is not really it's just taken as behavior, like they want to be aloof, they don't really want to interact, but it's actually because their periphery is a lot stronger than their central vision, and so they're using their periphery in order to look at things because it's clearer for them to see. So they are looking at you, that's where they see better. And so with central vision training, when that becomes as strong as their periphery, then they will look, they will look at you. And so that portion is what leads me to say that all autistic patients benefit from vision therapy. A case example here for autism, 10-year-old autistic female. She was, at the same time that I saw her for the evaluation, she was undergoing physical and speech therapy. She was unable to sit still or look at objects when prompted, and every behavior she had was always attributed to autism. After the evaluation, she needed a little bit more work, 40 sessions this time. When she graduated, both in office and at home, both portions of the customized vision therapy program, there was a dramatic improvement in her behavior. She was able to interact with others and play with her classmates. She was able to make eye contact, and that was huge for her mom because now she felt like she's able to bond with her daughter more. And so because speech and occupational therapy are linked so closely to vision, I had interacted with both of these therapists during this case, during vision therapy for this patient, and they have noted a significant improvement in increased speed and responsiveness for their therapies as well, once she was able to use her eyes, you know, in a more accurate way in order to lead the body into all these different exercises and demands that she needed in the day in school and in her therapies. So going over the overall process here for a patient coming in that may or may not have some of these, may be a good candidate for vision therapy or not. A comprehensive vision exam is key to rule out any other issues. You definitely don't want to start, doing vision therapy on, peripheral training on somebody that has visual field loss that's just permanent, because we won't get anywhere. So we want to make sure they're a good candidate first and that they will benefit from it before we start anything. So, or looking at their visual fields, MRIs, any other doctor reports after either if they're adults and it's after their traumatic brain injury or stroke, or if they're kids, just you want the overall background of that patient. Then we would move on to the visual efficiency and information processing evaluations in order to ensure the patient candidacy and make sure it's a good prognosis for this neurological visual rehab session before we even begin. The result analysis and report is generated for the patient or parent. Afterwards, I usually just send them a report within a week of both of these evaluations. And then neurological visual rehab sessions with the prescribed home therapy begins. And so the therapy is once a week, and then they repeat those exercises at home. They get a kit and they just repeat them at home for the rest of the week. So that repeatability and compliance with home exercises is key in order to move forward and increase the level of difficulty for the exercises that are prescribed, so we can eventually abate the symptoms. There is a progress evaluation every 10th session, which is in 10 weeks, with another report and patient or parent consult. And then once they graduate the in-office portion of vision therapy, then they have maintenance home activities and follow-up evaluations during the first year in order to prevent regression. So we usually want to taper off the maintenance exercises until we're sure that there's no regression occurring between progress evaluations and it has become a part of their visual system. So vision therapy is not lifelong learning by any means. We're just rewiring the brain, strengthening it, making sure it's repeatable. Now that we're looking correctly and using our eyes correctly, making sure that that's repeatable and an innate part now of the person's visual system. So visual efficiency evaluation, a little bit more in depth here of the evaluation itself and what it entails. We are looking here at how the vision is affecting activities of daily living, school, sports, work, anything that they need to do to get through their day accurately and safely. So with visual efficiency skills, we are looking at depth perception, at ocular teaming, eye tracking, eye focusing, the accuracy of their vision and how they're using both eyes together. We're looking if they have any strabismus or amblyopia, how their peripheral strength is, any visual field loss, and whether or not they have eccentric fixation. So like it showed before with case studies, having 20/20 vision does not eliminate visual efficiency skill deficits. It may not have anything to do with whether or not they can clear each eye by itself as 20/20. If they can't use them together, then we still have an issue. And then for the information processing evaluation, so this one we are looking at things like directionality, laterality, reversal, fine motor control, visual motor integration, visual memory, visual discrimination, and visual attention. So are they able to pick something visually from a visually noisy background, can they actually detect what they're looking for quickly and accurately, then can they go for it and grab that thing only with their motor coordination as the eyes are leading their body to do these extra, things in the day. These are all having to do with information processing. So it's another leg of neurological visual rehab that not all patients would necessarily need therapy in. Some patients may just have eye teaming and eye tracking issues, but most of the information processing comes from, or is the need of it comes from traumatic brain injury, ABI, and special populations. So post-evaluation consult here, after we're done with both visual efficiency and information processing evals, we have a patient or parent consult, the summary report of the findings, my impressions and recommendations for the classrooms while that patient is in therapy, because we don't want to waste that school year. If we can accommodate in the classroom as the eyes are getting stronger, then we're giving that patient a little bit of an advantage, in order to do the best he can until his eyes are strong enough. This report can be shared with all providers and teachers. I actually urge the parents to share it with as many professionals that work with their kid as possible in order to enhance the comprehensive care and provide continuity of care. And so the neurological visual rehab is best functional when it is inside an interdisciplinary rehab team. And so when, I get referrals from neurologists, ophthalmologists, internists, and then there is a discussion back and forth and reports that I get their reports and I send them my reports. Then when we see that patient, we really have a comprehensive idea of what's going on, what else he's doing in order to fix his deficit. And it also helps everybody gain a new perspective about their patients and also just increase their knowledge about other things in the medical field. So when we,
please, yes. Can I try to give in French what's all about in order to...
Oh, absolutely.
So, Dr. Yamam Mouradi est en train de nous présenter un thème qui est très intéressant et qui intéresse notamment les optométristes qui voudraient commencer à prendre en charge un certain nombre d'aspects liés à la réhabilitation neurovisuelle. Elle a présenté, si vous voulez, des statistiques au début pour montrer l'impact, si vous voulez, la prévalence et de tels troubles qui ont des répercussions sur la vision globalement et sur le comportement. Parmi les symptômes visuels à titre d'exemple de ce qu'on appelle la commotion, la concussion, ce qu'on appelle un accident qui affecte le cerveau, nous avons parfois des problèmes d'acuité visuelle, nous avons parfois aussi des pertes de champ visuel, des dysfonctionnements oculomoteurs, des troubles de la convergence et de l'accommodation, photophobie, une attention visuelle réduite. Donc, un impact qui touche le cerveau peut affecter la posture de la personne, son équilibre, ses aptitudes motrices globales et très fines, la compréhension, la cognition, l'attention, la concentration, la capacité d'apprendre, la productivité et aussi les activités journalières. Il est évident que nous avons un panel très large de cas qui peuvent se présenter. Elle a insisté sur le fait que les traumatismes touchent beaucoup plus de personnes âgées parce qu'ils perdent leur capacité, si vous voulez, à discerner les choses, soit par une baisse de la vision, soit par des troubles de l'équilibre. Et donc, il y a une fréquence assez importante pour les personnes au-delà de la 75 ans. Par la suite, à côté de ces aspects qui sont liés à ce que nous rencontrons parfois dans notre pratique quotidienne, toute la question elle est un petit peu d'ordre, si vous voulez, comment comment d'abord évaluer les personnes qui ont ce déficit, comment les reconnaître, comment les dépister, comment retrouver ces gens-là, et comment, avec une méthodologie, comment les ramener. Elle a déployé une panoplie de tests. Je pense que je pense qu'elle a utilisé le Brain Injury Vision Symptom Survey. Is it that right? You have used the checklist?
Yes.
OK. Qui est un test, si vous voulez, de notation des incapacités ou des capacités de l'individu pour différentes tâches. Et aussi, c'est un questionnaire qui permet aux patients d'expliquer ce qu'il a comme trouble. Ensuite, elle a introduit d'autres examens qui sont nécessaires, que nous utilisons, le test d'activité visuelle, le champ visuel, comment retrouver les dysfonctionnements oculomoteurs, les tests de vision binoculaire en général. Ensuite, bien sûr, les troubles de l'accommodation. Donc, ce sont tout ce qui est cette histoire d'amplitude d'accommodation, de facilité accommodative, d'insuffisance accommodative. Elle s'est intéressée aussi à la convergence parce que les deux fonctions sont liées. La photophobie, qui est parfois c'est une plainte sous-jacente, mais qui ramène beaucoup de patients chez nous en pratique, ou bien la difficulté à discerner entre ce qu'on appelle la photophobie et l'éblouissement, qui sont deux choses complètement différentes, l'éblouissement étant un autre aspect. L'attention réduite, elle a parlé de ces déficits chez un certain nombre d'enfants. Elle a cité le cas des autistes. Donc, sans plus tarder, donc, I have tried to give a brief description of what you have introduced up to now. So I will let you the screen. Thank you.
Thank you. Yes, so the benefits of this interdisciplinary collaboration is to really give everybody a holistic approach that dramatically enhances patient care and the ability to provide the most comprehensive patient care and prevent symptom remission. We don't want to be doing all this work in occupational, physical, vision therapy, but each person kind of doing their own channel and not seeing what else is happening to the same brain, that remission occurs, and that's, the patient just is the only one who loses at that point. So what can you do? One of the main things, like we discussed, is that acquired brain injury visual symptom checklist is to add it as part of the routine paperwork in office. And so, just like you're looking at their medical history, their allergies, this page is key in order to detect these patients. And then the other thing is to just spread your knowledge and educate about neurological visual rehabilitation to your colleagues, to your patients, that yes, this is an option other than surgery or only prisms and glasses and contact lenses. These are the references. And, thank you very much. And, let me know if you have any questions, if you want to discuss any any cases. And again, my email was at the beginning is dralmouradi.vision@gmail.com. And then the patient and provider education Facebook page is Vision Therapy Dr. Almouradi. And so I post a lot of different things on there for the patients and for the providers, information about traumatic brain injury or symptoms, or just different tools to help the traumatic brain injury and visual efficiency community.
Okay, thank you very much, Dr. Mouradi. I was just would like to ask you about something very basic. How to bring all these people care who are trying to find a profession who can take care of their visual health into your practice. How do you have some people who refer to you such case, or do you do a screening when you receive people who have some kind of?
Yeah, so a lot of different avenues. The first one and the main one is internal referrals. And so in my office, there are 4 different optometrists. 2 of them see pediatric patients almost exclusively. And we've talked about different things that they could do in order to detect visual efficiency issues without taking up more chair time than they intend for their primary evaluation. So things like near point of convergence and age norms for how close can a patient cross his eyes and not see double, things like accommodative, strabismus, for example. If you find strabismus, you have to refer. So just easy things that are already incorporated into the primary care field that are just flagged for a visual efficiency or information processing evaluation. So most of my patients are internally referred. I do vision screenings in a lot of different elementary school districts. And so during that screening, it's a little bit more comprehensive. When I do the screening, I'm also looking at NPC and accommodative paresis, referring that way through the school and the district nurse. Then other than that is just provider education. So something similar to this webinar where I go into neurologists or ophthalmologist offices and teach them about it and how they can detect it easily. So, and that's why the symptom survey, I think, is one of the easier ones when we go outside of our specific ophthalmology practice. If we're looking at neurology, they can just add this page to the plethora of paperwork that the patient has to do to enter. And so they just end up faxing me the patient case, and I reach out to the patient that way and to begin just to do the evaluation. So those are the main ways to getting the patients. I do have some referrals from local optometry offices as well that I have just made connections with the doctors over the years. You're muted.
Sorry, I think I have had once I have read somewhere, or I have been watching a webinar of Dr. Paul Karpicki, who is using prisms to treat trigeminal dysphoria.
Yes.
Have you had any kind of such? Is it worth to use such a prism when we have some kind of dysphoria?
Yeah. Yes, so prism is used in vision therapy as a therapy mechanism rather than a neutralizing prism for strabismus or different things that you just prescribe to a patient and it's more passive. So this is in vision therapy, it's not neutralizing prism, it's active. So if they have a convergence issue, you actually want to put a prism that diverges them so they can really work on strengthening their convergence and vice versa. And so that is one of the main things that I do use in vision therapy in the sessions themselves. It depends on the patient. So some patients can't tolerate prism at all, even if they are with other therapies able to converge. The minute you put a prism, it's double. And so you have to do a prism consult at the beginning and see whether that patient is a good candidate for prism and they don't get nauseous and have all these other asthenopia symptoms. But when they don't have those and they are good candidates for it, it's great. It works very well, as therapy.
So when you are using prisms to strengthen either convergence or divergence, do you do the classical way of the 21 points to assess every step of the case, or do you just use a kind of test of Mallet test or such as techniques which are very quick?
When I'm during the assessment, not the therapy, you mean? The assessment itself? Yes. So I do the nine points of gaze. And so that usually gives you an accurate, at distance and at near. And that's usually enough to tell me if whether or not there is something like an A pattern or V pattern, exotropia, for example. And then for neutralizing as well, I know there's you use the 1/3 of what their prism to neutralize. It doesn't translate well from the book to the patient, and it really has to be how much can they tolerate without blurring, and when is that first threshold point where they can fuse and the objects. That's really what prism they need. It doesn't matter if it's 1/3, if it's almost all of the neutralized almost all of their eye turn. It really depends on that patient, and you have to trial it. So after the trialing, I have them walk around with it, make sure in the office that the walls aren't caving in, they can go up and down stairs and everything, so it's safe. And so there is no clear-cut number for that as well.
Okay. I was actually asking about the OEP 21 points, which are kind of assessing accommodation and versions and so on, and to determine to find the amount of prisms who would help people who have some kind of insufficiency, convergence insufficiency, or excess of convergence and so on. That's what I would.
Yeah, okay. So if they have convergence insufficiency but no strabismus, I usually don't use any assisting prism, any neutralizing prism. We go straight into active therapy so the prisms are not more of a crutch there helping their eyes. If they do have strabismus and it's a large magnitude, then I would use prism and slowly taper it off as their eyes get stronger. But if it's only convergence insufficiency with no strabismus, no prism is used. And then once they are in, we reach higher levels, more difficult levels of therapy, then I would use the opposite of the prism I would have used to help them in order to really improve their visual system, flex it even more and enlarge the range.
Okay, thank you.
So yeah, I usually don't use the 21 point.
Okay, I was just asking about how you. Another point, if you don't mind, it's about dyslexia.
Yes.
You have been talking about difficulties of reading and some trouble who can impact the visual aspects of some case. Dyslexia. Do you have some case of dyslexia who are in your practice? Do you have any background about that?
So usually for dyslexia screeners, they occur in school. And so if that student, the teacher or the parents think that he or she may have dyslexia, they usually run that screener in their school, and I just look at the data. Sometimes even with dyslexia patients, there is some underlying visual information processing issues, such as visual discrimination and visual form constancy. And so it could be just a developmental skip. So for example, the first thing we learn, is a pen is a pen. It doesn't matter what's moving, but a P and a Q are different. And so it's a whole new level of understanding to get to letters and numbers. B and D, same thing. And so if the patient is stuck on, well, this is still a pen regardless, then that could be something that's more visual information than dyslexia. So there has been some cases where there are, I do see dyslexic patients, and we take care of any underlying visual information processing issues, and then they go on to dyslexia, therapy and things like that, where it's outside of the scope of vision.
What about sometimes I have had a month ago a case, a woman who had 84 years old, who came into my practice. She was referred, and she has actually a horizontal diplopia, and and when her RMI was clean, nothing wrong. She has a palsy of the right, the lateral, right lateral muscle. So it was a kind of limitation of the abduction on the right side. She came to get a prism actually, but to neutralize diplopia. So when I asked about all the background, she was diabetic, non-insulin dependent. She has also high pressure blood, but everything was all right. When I didn't want to hurry up prescribing prism and so on, so I asked her to see her again in 3 weeks, and she came last week, and everything was gone. Nothing. She had nothing. She had a good abduction on the right side and everything. So sometimes, because you were talking about neuroplasticity, which meant for us a long time ago that a child of more than 6 years of age is able to have neuroplasticity, but older than that, it's not possible. And now we are looking again back at this sort of hypothesis, and we see that it's not true. That some people who are older than that, even in the elderly age, they can recover a good all the aspects of their vision, of their oculomotor function. So
absolutely, yes.
You have such cases sometimes. So you don't you give your time to see what is happening without going directly to therapeutics or techniques.
Yes, of course. And so that's one of the main things with getting the medical history of that patient before beginning and doing the evaluation to make sure we're ruling out everything else before we think that it's just something about that neurological visual rehab can do. And so in your patient case, it was most likely the diabetes was not under control, which caused that strabismus, and then she got it back under control. Her eye went back into place. And so that is something, and that was perfect that you just said, let's wait and see, rather than just put her in prism. That could maybe have a negative effect after those 3 weeks when her eyes were trying to go back to normal, but now she had prism. And so that's one of the main things in diabetics. I'm very hesitant to do anything until everything is under control for at least 6 months. Blood pressure, diabetes, their medication. If there's any medication change, I always ask them to let me know, because there are medications that would cause blur or double vision, and that wouldn't be something that we can fix until the medication dose is changed or they're more compliant with taking it. And so that's definitely something to look at primarily. And that's why the initial primary care evaluation is key, and then all the history before we do anything more specific. And then, yes, the neuroplasticity, absolutely. I have a 36-year-old nurse. She doesn't have any traumatic brain injury. She just always had amblyopia in one eye, was basically balanced in that eye, and they just focused on clearing her good eye. We have been doing vision therapy for, I think, 17 sessions right now. Her amblyopia went from 2400 to 2040. And she's 36. And so they don't have to be 7 years old for this to work. I have another athlete that was a motorcycle daredevil. And so he got a motorcycle accident, traumatic brain injury. He was seeing double in all these different gazes, not just straight ahead. So, driving even to just regular work was unsafe. He was very limited in his activities of daily living. But he didn't have any other issues like diabetes, blood pressure, anything like that. And he's not diplopic anymore after vision therapy. And, you know, he's in, older, he's a young adult. And so there's no age that is definitely old school. Those textbooks.
Nevertheless, I have seen that it's maybe sometimes more than 30 sessions, and compliance is very important in such case.
Yeah, absolutely, because they're coming in weekly and they're doing homework basically. And so when they're in school, they're students, they have all the schoolwork and they have to add this to it in their day. When they're adults, it's very hard to get this done every single day when they have all these other obligations. But compliance is key. I usually terminate therapy if that patient just doesn't comply, because then we won't be successful in it. It'll just be wasting time.
What do you use as a home exercise? Do you use broke cards or some
Yes, I usually don't do as much computer just because of the issue with screen time. So especially during since when COVID started, everybody was online, and so we were having a lot of issues with computer vision disorder. And so I like to use more free space things. So, different cards for convergence, Brock string, different lenses and prisms to try to clear things, heart charts and different things like that for tracking. It's usually all either paper, or I do some apps, especially for autistic patients, because it keeps their attention, it's colorful, it's moving. But for the most part, I don't like using screens as much because they're already visually fatigued. So you don't want to add to that. A lot of red-green, red-green glasses and red-green sheets. Yeah.
So do you have a panel of means to give to your patients for their home exercise? From which age do you give? It's difficult for a young kid to use.
Yes. So I usually start vision therapy at the youngest I start is at 5 years old, but they have to be a mature 5-year-old where they are listening, to instructions and doing their work. And then usually when they're younger, it's really with the parents, just telling the parent, this is the homework, this is what you're looking for when you do it at home. And of course the exercises change depending on the age of the patient. They're all going into the same goal, but we just have to make it more interesting for younger patients so that they can keep doing it. I also have to make a lot of variety for them so they don't get bored with it. Even if they haven't leveled up, we have to do the same exercise a little differently so they aren't bored. So most of my patients really start at 6 or 7 years old, but I have seen some younger ones where, especially if there's strabismus and the parents are very concerned, they don't want to wait till the patient is 6 or 7, we can start them a little bit earlier.
The involvement of the parents are very important, I think.
Yes. Absolutely. And then when they're younger than that, if there is a problem that's major and can't wait, then I usually do passive therapy, such as patching, where they're not coming in and doing sessions, but we're kind of doing maintenance passive therapy until they're old enough.
Yes, patching I think has developed other way. Now we know that patching all the day is not worth to use because it has some.
Yes.
Yes,
2 hours a day, 2 days a week has the same efficacy.
Exactly.
Yeah.
So
yes.
there are some studies from the pedic and the motors, I think, who have given us the ability to see such that improvement is a kind of dose dependent than you have to have 2 hours a day, better than having all the day, because it has an impact in the psychological side also of the kids.
Yes, exactly. I usually, the patching is only done at home, not in school, and it's only 2 hours a day, 2 days a week. And it also has to be with near tasks. The person can't just be watching TV and patch. They have to be doing some hand-eye coordination tasks in order for patching to really reach its maximum effect. And, there are other things like atropine, for autistic patients or patients that just won't comply or they're too young to comply with a patch. They always want to pull it away. So we do atropine therapy as well.
Okay. I was just the last question, I think, because it's time to leave you to go to work. It's Friday. It's a day of working at the end of the week. The other aspects which I am trying to work on is a kind of you have to have a kind of network where you have the ergotherapists, you have the occupational therapists, you have neurologists, you have an ophthalmologist. All these people have to work together to bring a kind of support and to the patient. Otherwise, you can't do on your own this. So how do you? How you told me that you are visiting sometimes ophthalmologists and neurologists and so you have to be very dynamic in around the health people to keep everything going on. It takes time also. It takes time.
Yes, it can't be seeing patients all day, and there's a lot of outreach going on outside the office. Yeah.
Why I am asking about that, because today optometry is more involved with refraction and with also contact lenses. And with this new way of scleral contact lenses and so on. So they are traditionally, before that, I am quite, I had my graduation in the 80s of last century. So my way of looking at things, that vision is a holistic aspects. So we have to see all these aspects before going to a problem, fine problem, a particular problem. And this is because some young optometrists are watching this webinar. So your advice to bring people to encourage people to be interested with neuro-optometry, what would you advise them? What they should do?
Yes, so it's difficult because I know there are, each country has different subcategories in the optometry university, and so I know the focus is usually refraction, contact lens, but if you look at ocular disease, if you look at strokes and different issues, it is all in the visual cortex. We learn neurology in optometry school, and so it's a waste to learn all this stuff but then not use it and just worry about myopia, hyperopia, astigmatism, where most of the population is okay with just glasses, but you're really improving an entire person's life when you are making them not double, when you're letting their visual system be rewired instead of just giving them a crutch where they take off the glasses and they're double all the time, even if prisms do work. So this is really looking at a holistic medicine. It's not just you're not just like putting band-aids. You really want to get to the core of the problem with these patients. And when they are overlooked, then they're really marginalized in society because they can't do their activities of daily living. So a lot of my adults come in and they're like, I lost my job, I can't work, everything is double, what am I supposed to do? So this is a livelihood of a whole family that you're fixing if you just get that patient to be functional again. 80% of vision of learning in the classroom is visually related, and so that kid won't reach his potential if they can't see in the class. And so I think it's very important. And there are simple things you can do even if you don't have a full neurological visual rehab department in the optometry school. You know how to work with prisms, you know what NPC is, and you know what convergence is. You can diagnose strabismus. You understand the mechanism as an optometrist of what the eyes do when they converge and diverge. And so the good thing about vision therapy is that you can customize it in any way you want if you know what your goal is. So as long as you know that we're working on convergence, they can just do pencil push-ups, you know, anything, it will be helpful rather than just brushing them aside and saying, no, here are glasses. If they don't work, too bad. We can't do anything more, because we're a wealth of knowledge. And when we're interacting with all these other neurologists and internists and ophthalmologists, we can really learn. You don't stop at your degree, you know, you have to continue learning. And just like you said, there's scleral lenses, new contact lenses come out all the time. So that continuing education is key, and this is part of it.
So if you want me to give in French to summarize what we have been talking about. La neuro-optométrie, aujourd'hui, elle connaît un développement assez intéressant, notamment en Amérique du Nord, aux États-Unis et au Canada. Elle est partie intégrante de l'optométrie. Ce que nous apprenons, ce que nous expliquait Dr Mouradi, ce que nous apprenons dans nos instituts d'optométrie, on fait beaucoup de neurologie, de neurophysiologie, et tout ça semble parfois être déconnecté de notre pratique quand on va se verser dans l'activité pratique où nous allons nous intéresser à la réfraction, nous allons nous intéresser à la contact, etc. Donc, la chose est que, au fait, la vision, elle est d'abord un processus cortical. Donc, qui va impliquer le cortex visuel, qui va impliquer donc le cerveau. Et par voie de conséquence, l'approche holistique, si vous voulez, l'approche globale, est d'essayer de concevoir que la vision est un processus cortical. C'est vrai que les yeux vont jouer un rôle pour pouvoir recueillir, il faut que les yeux soient en bonne santé pour recueillir ces images et par la suite pour les traduire en photons électriques pour que ça aille vers le cerveau. Mais au-delà des yeux, il y a le système visuel. Et l'approche qu'a développé Dr Mouradi, c'est qu'il y a beaucoup de déficits qui paraissent parfois, qui ne sont pas apparents, qui sont latents chez un certain nombre d'individus, qu'ils soient jeunes, moins jeunes ou plus âgés, et qui parfois se présentent à nous, et comment les appréhender, les évaluer et ramener une approche thérapeutique à ces individus. Donc, elle a parlé elle a cerné, si vous voulez, les aspects liés, par exemple, aux commotions, donc concussion, cortical visual impairments, TBI, etc. Ce sont ce qu'on a comme accidents, traumatismes, parfois de petits accidents qui vont affecter toute notre vie parce que simplement, ça nous a perturbés. Et vous avez vu l'histoire du coup et contre-coup. Ça nous arrive souvent de heurter un mur et puis par la suite, on a des déficits dont on n'est pas conscient. On a des symptômes, on a une plainte, mais quand on arrive au niveau chez un optométriste, qu'on expose notre problème, il semble être un petit peu bizarre parce que ça n'a rien à voir avec la myopie, l'hypermétropie, l'astigmatisme auquel nous sommes habitués. Ce sont des cas qui sont assez particuliers. Et c'est évident que si on sait évaluer le punctum proximum de convergence, le NPC comme Near Punctum of Convergence, l'amplitude d'accommodation, la motilité, les 9 positions de la motilité. Ensuite, il y a un certain nombre d'aspects qui peuvent, la pupille, les réactions de la pupille, tous les réflexes, la triade. Ça nous permet déjà d'évaluer l'aspect, si vous voulez, un petit aspect du processus cortical. Et à partir de là, on peut, avec le questionnaire qu'elle a introduit, que je vais peut-être essayer de traduire parce que c'est un questionnaire qui est très intéressant. C'est comme le questionnaire sur la sécheresse oculaire, c'est un questionnaire qui va permettre de poser le diagnostic. Y a-t-il un problème nécessitant une approche neuro-optométrique de réhabilitation visuelle où il n'y a pas ce problème-là? Donc, pour discerner, et là, elle a parlé de l'autisme et nous avons parfois des cas d'enfants qui sont ramenés. J'en ai eu des cas qui sont ramenés. On les évacue en les orientant vers des psychologues. We have sometimes some autistic people who are brought by their parents. So what if I can assess the visual aspects, what I would say, I would try to do a refraction and to send them back to the psychologist, saying that it's not my field. It's a kind of c'est une sorte de frustration. It's kind of frustration for us. So, ça nécessite à ce qu'on s'intéresse à ces cas-là et qu'on fasse notre part de la chose pour les aider parce qu'ils sont les parents les ont ramenés pour essayer de trouver une aide. Il est vrai que c'est un travail qui nécessite peut-être l'intervention du psychologue, du neurologue, etc. Mais c'est un travail aussi qui concerne l'optométriste. So I have tried to give a summary of what you have been talking about.
That was perfect.
Thank you again, and I hope that you will send us the handout so we can
yes, absolutely.
Files in the files of the group. And thanks a lot.
Yes.
And
Thank
I hope
you.
that we'll see you again next time.
Yes.
Thanks a lot.
With new topics, and we'll kind of go from here about more in-depth topics. Yes.
Inshallah.
Absolutely. It's my pleasure.
Wow.
Inshallah.
Bye-bye.
Thank you. Bye.
You're welcome.